Hello, everyone, and welcome back to The Loop. Today, we have a very special episode in honor of Black History Month. This kicks off our Season 2, which is a roundtable review series, where we dive into important topics with special guests. Don't worry, we are continuing our in-service review up until the exam, but we could not ignore this opportunity to highlight these leaders of our community in plastic surgery, as well as discuss the critical issue of health disparities amongst African American patients. Your hosts for today are myself, Dr. Morgan Martin. We also have our co-founder, Greta Davis.
Hi, everyone. I just want to say thank you to our guest speakers for joining the conversation. With the changing political landscape and a lot of focus on the literature on how race and ethnicity impact both trainee and patient experience, it's so important that we have these discussions. So thank you for being here. Some things we're going to talk about are a little bit about the historical context behind existing disparities in healthcare, ways to improve trust and care of vulnerable patient populations, and lastly, how to improve representation among practicing and training plastic surgeons.
Thanks, Greta. So we have here also our core host and executive director of marketing, Dr. Sanam Zahedi.
Hey guys, thank you. I know these conversations are really hard to have, but sometimes change in understanding needs us to have them. And so that's why we appreciate all the guests for being here and sharing their perspective with us and everybody else.
All right, so our guests include Dr. Wilton Triggs II. He is a plastic surgeon in Gallipolis. I know I did not pronounce that right, Ohio. So welcome.
Thank you. Thank you guys for having me.
Yeah, we also have Dr. Michael Keys, an independent plastic surgery resident, just like myself and Dr. Zahedi at University of Louisville. Welcome.
Hey, thank you. Thank you.
Yeah, and unfortunately, we had a third guest today, Dr. Namaka Nuaba, a plastic surgeon in Nashville, but she's busy with an emergency, so we're going to have her back at a later time. So thank you all for being with us today. So let's start off with just having introductions from our guests.
Dr. Triggs, what is your background and what has influenced your career?
So I'm a general plastic surgeon for a hospital-based practice in Gallipolis, Ohio. I'm in my second year of practice. I started in August of 2019, fresh out of training at the University of South Florida in Tampa. I did an integrated program, which was 6 years. Prior to that, I went to medical school at Meharry Medical College in Nashville, Tennessee. And prior to that, I did undergraduate at University of Alabama at Birmingham at UAB, where I got a degree in chemistry with a minor in mathematics. What inspired me, so my journey into plastics was kind of late in the game. I feel like when you go into a subspecialty, a lot of times people come into med school knowing exactly what they want to do. I thought I knew what I wanted to do. I thought I wanted to be a neurosurgeon. And during my first year, I did a lot of shadowing and just saw that it didn't fit my personality. And so I did like a 1-month mentorship with the American Academy of Dermatology because my grandmother died of melanoma, which is kind of rare in the African-American community. Wow. And so I was interested from there and did a 1-month rotation. And during my Mohs surgery week, I really liked the surgery aspect of it, dealing with skin cancer and things like that. So one of the residents suggested that I should check out plastic surgery. And so I did a 2-week elective at Vanderbilt University and loved it. And I followed that up by doing some away rotations at the University of Kentucky and then did a full month rotation at Vanderbilt. And the rest was history. I just liked it because you can truly be creative. There's no one set thing to conquer a question or a problem. And I feel like it's like the true problem solving, specialty. You go in there thinking one thing and you may have to revamp the whole plan. I think Mike Tyson said it best. Everybody has a plan till you get punched in the mouth. And I feel like that's like quintessential plastic surgery. So that's kind of what brought me into the specialty.
Yes, that's very true. Yeah. All right. So Dr. Keys, tell us about yourself and what are your plans for the future?
Hey, everyone. Thank you so much for inviting me to speak. My name is Dr. Michael Keys, and I'm a plastic surgery fellow at the University of Louisville. I completed my general surgery training at the University of South Carolina in their Myrtle Beach program. I went to medical school in the University of Miami and did my undergrad in the University of Florida and majored in integrative biology. I call myself Blackanese because I'm half Black and half Japanese. And so that's why I have a unique experience, I guess, and I'm happy to have this conversation today. I am also the founder of Celebrity Plastics on Instagram, where I talk about celebrity befores and afters, as well as the latest and greatest cosmetic surgery procedures. My plan is to finish fellowship next year, and then I plan on taking Celebrity Plastics from an online platform to a brick and mortar practice, location to be determined.
If you're not following on Instagram, you're probably one of the very few who hasn't. So just if you're listening and
Yeah,
you're
that's
not
true.
following him, go ahead and follow him.
Thank you. Thank you.
Yeah, absolutely. Thank you both for those introductions. We're so excited to have you here and have your perspectives on, just such an important issue. And so let's just get started. There are not enough UIM physicians or trainees in the field of plastic surgery, period. It's a problem. There's a lot of data supporting that. So I just wanted to start off by talking about some challenges that are faced by applicants and trainees that might be responsible for the lack of diversity in the field.
Yeah, so I feel like with the pipeline being so small for a lot of minorities coming into medicine, with a small sample size actually getting into medicine, a lot of them are coming based off like either mentors or something they experienced when they were younger. So a lot of them go into primary care based fields. So they had like a real, like big brother, big sister relationship with maybe their pediatrician or their family doctor, or their OB-GYN. And so they come in there wanting to be like that physician, and nothing really steers them away unless, during third year, during the clerkships, they get an experience like on surgery. And a lot of times, outside of surgery, they don't go into the subspecialties to get that experience. A lot of people come in there with preconceived notions. Like even myself coming into medical school, I didn't know the full, gravity that is plastic surgery. All is what, the media portrays. And so something that, that could be done is something I did myself is I went back to my alma mater in med school at Meharry Medical College and did their young alumni speaker series. And I talked about plastic surgery and I talked about the whole specialty, basically gave a general overview showing wounds, hand surgery, microsurgery, breast reconstruction, showing them that, cosmetic surgery is part of plastic surgery, but, it's part of a wider umbrella. And so I think that's one way to kind of increase exposure into plastic surgery. Now widening the pipeline of getting more minorities into medical school, it's a little bit difficult. I think a lot of minorities coming into college, some are interested in engineering, some are interested in other like disciplines. The only thing you can really do is kind of like increase exposure to medicine in general, maybe, during like undergraduate orientation where you can have like medical students come and do free checkups to kind of get them interested. Like, oh, well, maybe I could go to medical school. Somebody that may be coming in thinking engineering, they get exposed to maybe a presentation during their freshman orientation and boom, you may hook them. I think just things like that, like almost like a grassroots effort is the only way you're going to kind of increase, well, not the only way, but one of the ways you can increase it. And then you can also go to local high schools, giving them exposure, because a lot of times, especially those in low socioeconomic status, they don't really see physicians unless it's an emergency. And a lot of times when they're seeing them in an emergency, it's not a good situation. And so it's almost traumatized. And so it almost deters them from like becoming, even thinking about that. So if you can like catch them early, like different high school programs or even in middle school, and sometimes you even have to drop down to elementary school, with the pediatricians coming there, being nice, letting them use your stethoscope, showing them different bones and things like that. It's all about like, the more exposure in the earlier, you can kind of keep like water, plant the seed, then you just kind of keep watering the seed. And then maybe, subconsciously they may declare pre-med and all of a sudden, they're hooked and you got them. So I think that may help feed more minorities into a medical discipline. And then from a medical discipline into plastic surgery, it's almost the same concept of like planting the seed by exposure or presentations, and then, just keep watering the seed. Vanderbilt, they have like a first year and second year curriculum geared towards those just interested in plastic surgery, which I haven't heard in any other institution. So those are just my thoughts.
I have to say, based off of what you just said, I firsthand have seen it. So when I was at UTMB, he's not a plastic surgeon, but a very famous CT surgeon, Dr. Okereke. I want to give him a huge shout out, because if anybody's at UTMB, they know about his high school program. And he literally has reached out to the Galveston community to try to bring in, like you said, middle school students and high school students, and he would have suture workshops with them. He would try to, incorporate residents. So it would kind of be a teaching experience on both ends. You have residents doing the teaching, but at the same time, he's there to also help out. And it was what you mentioned, it's like creating a spark, creating an interest in the students, and it made a huge difference.
Yeah, I think that's an amazing and very important point that you make. It has to be something intentional. You have to be creating these opportunities for people because there is interest there. One thing that we're hearing a lot when we speak with our pre-medical mentees is that, they want to get in the clinics, they want to shadow, they want to have these experiences, but there's not a route for them, especially for someone at a smaller institution where there isn't a hospital nearby. Sometimes it's, private practitioners, but all it takes is someone to reach out, say, look, here's the pre-medical advisor. I'm going to reach out to them and say that there's an opportunity available to get the word out there and get people in the door. So I do think it really needs to be something active to make sure those opportunities are available.
All right, Dr. Keys, do you have any thoughts about that?
Yeah, I definitely experienced a lot of challenges in my career and training that directly stem from being a minority. I think one of the biggest challenges that I face in my training is just the general lack of diversity, both in residency and fellowship. I was the only Black general surgery resident in my program, and currently I'm the only Black plastic surgery fellow at my program as well. And as a matter of fact, there are no Black faculty in either program as well. And so you can imagine that there were definitely situations where I felt like I was being discriminated against or even made fun of because of my ethnicity. This can range from like locker room kind of backhanded comments or certain types of jokes attributed to stereotypes attributed to Black people. Even though most of the comments were probably not intended to be malicious, I think it just showed the lack of understanding that comments like that can slowly whittle away at one's ego and can affect my confidence and so forth. And so because of the lack of diversity, I didn't really have any kind of recourse or anyone I could turn to who could truly understand what I was going through. And this can even reflect on the patients that I've encountered as well. I've definitely had patients that refused care and even fired me because of my skin color, which when you're dealing with a surgical problem, it can be a big issue because if a patient needs surgery, there's not really many other people in the hospital that can offer assistance. However, luckily my attendings at the time were very understanding of the situation, but it definitely hurts to experience that kind of treatment because we put in the same amount of work to, get the qualifications and the experience needed to operate. And then we're just having a patient turn you away just because of, some biases that they have or some prejudices that they have. And so I think that, these are societal problems that we need to address. And I think that hopefully we can bring some more diversity into educational programs and get more people into medical school so that patients, feel familiar with the types of doctors that look like them and talk like them, and that can definitely enhance their care.
100%.
Yeah, that's just crazy to think that that happens. And of course, I don't see it on my side because, I have that privilege. And then hearing stories like that is just terrible that it's happening every day. So I have another question for you guys. So I personally have not been around long enough to experience many of these interactions, but my attending has told me stories that demonstrate the continued mistrust of African American patients for physicians. And this included thoughts that even recommended surgeries were for perhaps experimentation or for practice. And these patients have fear of implants. And it can be almost a separate issue, but also difficulties with things such as transportation because of socioeconomic status. And I know a lot of this mistrust with physicians is deeply rooted in things such as the Tuskegee syphilis trial, which I'm from Alabama. So, I heard a lot about this growing up, especially in medical school. And for those not familiar with this or have heard about it, for 40 years, so 1932 to 1972, the United States Public Health Service and the CDC conducted an experiment on African American men to observe the natural history of syphilis. And again, this lasted 40 years, and they denied them the readily available treatment of syphilis. That's not that long ago, so 1972. It's clear why there's a serious mistrust with medical providers. So, what is your experience with mistrust or hesitancy of the healthcare system by minority patients? And are there other barriers to care that you have witnessed?
Yeah, so I think that's a big source of it, the Tuskegee experiment. And a lot of times they don't even know the full story. It's just like they know that something bad happened and it was dealing with Black people, people of color. I'm from Alabama, from Huntsville, North Alabama. So, this is like deeply rooted.
Right.
But I did a lot of I did my training in Tampa, which is pretty a diverse patient population, Black, white, Hispanic. But just getting African Americans to come, I mean, even in my own family, to come to the hospital, it has to be something like traumatic, and it's usually pain related or something where the symptoms are just severe, like pain or difficulty breathing or their heart racing. And at that point, it's almost like it's emergent at that point. Needs to be seen within
Right.
like 24 hours. And it's really because they're scared. Because they hear these stories. Oh, well, my friend went, my friend or my coworker went to the emergency room and they never came out. Well, your friend went to the emergency room when they were on death's door. And so the cards were already stacked against them. And so a lot of that, it's just like a combination. And then you hear, even with the COVID vaccine, there's so much misinformation out there. It just kind of like, compounds the problem. And a lot of it's coming from older African Americans that, witnessed a lot of the Tuskegee trials when it was like on the news and things like that. So it gets, almost like brought down or passed down like, oh no, you need to be careful going to the hospital. The only time they see like treatment is warranted if it's like a cut or laceration, something obvious, not really something internal from like a organ system standpoint. So how do you combat it? It's you just have to be in the community. You have to, you see it all the time. There's like a barbershop talks where doctors go into barbershops and talk to males either about mental health or doing blood pressure screenings and like developing a rapport. It's just like when you're meeting someone, on a date, you have to do multiple dates to really kind of open up and start sharing more with people, and people will share more with you back. And then you can kind of understand a little bit like their hesitancy about like receiving healthcare. And that's why, having a diverse healthcare system when doctors and other nurses and healthcare professionals comes into play, because whether you like it or not, sometimes people feel more comfortable opening up to someone that looks like them, and so that can definitely help. And being in the community and talking with other minorities or people of low social economic status can kind of understand, all right, this is what's going on in my body, and you have to be able to break it down to that level as well. Like in med school, I had a patient I'll never forget as a third year, and we were talking about diabetes, and they call it the sugars, and they really didn't understand like what was going on with their body. So I'm like, basically your pancreas or this organ is not really helping you regulate the sugars, so you're basically adding sugar into your bloodstream. Imagine it being like Kool-Aid, and the more sugar is not really being filtered out, so you're having like more and more and more of a sugary Kool-Aid, which you don't need. And it's kind of, it's tearing up your organs or the small vessels. So you have to kind of be able to paint pictures for them and talk to them on their level, or relate to things they may know. And, they'll get it. And then they'll start like, oh, you're such a good doctor. And you got to just spend time with them. I think another issue is like coming through the emergency room and their complaints not really being adequately heard, because you hear these horror stories. Like someone comes in like, yeah, I had this pain, and that person almost, gets sent away, and they die at home because no one took them seriously. And then you got to think about, there was like a pain study where they thought and this was recent, where African Americans felt pain less than, those of non-African descent. So they were like, yeah, they can tolerate pain better than we can. And this was like within 20 to 30 years, the study was done that medical students actually thought that African Americans tolerated pain better than any other race, which is, it's just scary and it's shocking. And so it's all about, I know, right? So it's just all about getting in the community, talking to people, increasing the diversity, and just really trying to, we've all been there when we're tired, we're seeing that last patient of the day, but you just always have to keep in the back of your mind to give them that due diligence and try to keep that hunger for trying to like do right or provide good care.
Yeah, I definitely agree. I mean, I think that, as Dr. Triggs mentioned, that misinformation is a big problem as well. And we need to do our best as experts to really combat it. All these misinformation stuff that you see on Facebook and stuff, you can always comment and give your expertise, and your friends and family will respect your expertise. And so maybe even try to comment if you see that propagating through your space. I definitely think that the Tuskegee syphilis trial had an impact in the mistrust of providers, and understandably so. And I also think that socioeconomics definitely is a huge barrier to care and disproportionately affects minorities. And so I think that, certain systems need to be put in place so that we definitely bring these people in and get them the care that they need. And a lot of these academic institutions provide that. Here in Louisville, we provide transportation and follow up and make sure that we call our patients afterwards so that they don't get lost to follow up just because they can't get a ride, for example. I also think, as Dr. Triggs mentioned, that providers themselves don't often provide the same quality of care to patients of color. I think that providers often brush aside complaints for patients of color and don't take them seriously. Recently, there was a Black physician who recorded her fight with COVID and the poor care that she received as a minority patient. The video went viral across mainstream media, and this doctor actually died after repeatedly complaining of being mistreated as a patient. And so, when you see stuff like that, that just really shows that this is going on, and this isn't just people like, oh yeah, they're just complaining. But this is actual factual, situations that are occurring. And personally, I try to counteract this by giving more of my time to minority patients if needed, because I know that they can appreciate seeing a familiar face. And, so I try to explain things to them, just like Dr. Triggs mentioned, on their language if I have to, and, get them through the plan, through alternate means if it needs to be.
So I had a follow-up question to that. And what are things that I can do as a Caucasian physician to help patients who are African American? Is there something specific that I need to work on that I can do better?
I think being able to make sure that patient walks out kind of knowing exactly what's going on. A lot of times, and I think this is any patient, they'll just kind of give you the head nod. Oh, okay. But you gotta have to all right, so tell me exactly what you think is going on, or explain to me, what I just told you, just to make sure it reinforced they know exactly what's going on. And I think just, just showing that compassion. Because as surgeons, it's hard. It's a rough lifestyle. To kind of get through residency. Our dynamics are not, the friendliest. You have to be edgy, and so I think showing a little bit more compassion, taking a little bit more time, and just making sure you ask them more open-ended questions to be able to get them to regurgitate what you just told them, and I think they'll appreciate it more. I tell my patients, and this is all patients, if you leave out here with questions or you don't understand, then I didn't do my job. And, even if I'm not booking you for surgery, you should walk out of here knowing exactly what's going on with you, my thoughts, and some of the options that are going on. And I tell my parents that when they go to the doctor, and, I tell my family members that, and that's kind of what I would do. It's just, open-ended questions, have them regurgitate to you, and just basically give them that extra time and needed, because they'll hit you with the head nod, like, oh yeah, okay, all right, and then they'll go home and not know a clue what's going on.
Right, that's a very good point.
Yeah, I think patients only take away like 30% of what you tell them in encounters. Like they've done studies that show that. So we definitely should take time to really explain things to our patients. And then also make sure that we don't take like an authoritative approach to our plans and make it seem like a team effort to really come to the best decision for the patient. Because when you attack things that way, then the patient feels more invested in their care, and they really, you have to understand what's going on in order to make those kinds of recommendations. And so, I think if you don't take that paternalistic approach, then that will be received better by these patients.
Yeah, I totally agree. I didn't even think about that, but yeah, including them into the decision making process. Like, hey, these are the options. This is what I'm thinking. What do you think? How's your living situation, or logistically, how are you going to get back and forth and things like that? Man, that is crucial. That's crucial.
Yeah, I couldn't agree more. I grew up in Iran and I wasn't familiar with the Tuskegee trials. So my question for you guys is, what can we do as a provider when patients come into the room? I know you're saying it's really hard for them to even go see a physician, but let's say they come see the physician. What are some of the things that we can do to help increase their trust?
I think that what you guys are doing, it can definitely increase the trust in this community. I think reaching out and working with providers of color can definitely bridge the gap and build trust in patients of color if they see that you're aware of these issues and are trying to do your best to, find a solution. I think maybe even providing educational material aimed at fighting misinformation would be especially beneficial to patients in this community. And as Dr. Triggs mentioned, go out in the community if you have to and really put yourself out there and try to address the problems that these people are facing. If you're having a patient who's undergoing breast reconstruction or thinking about breast reconstruction, and then they suddenly, are lost to follow up, maybe reach out to them and see what happened. Like, are they still contemplating with a different provider, which is absolutely fine, or do they have unanswered questions and are just afraid to come back? Maybe if we can find an answer to these questions, and you can definitely have better follow-up.
Yeah, I don't have any more to add than that. Just being compassionate, asking open-ended questions, and just kind of, I guess, the social aspect of what's going on in their life that may be deterring them from seeking care, or other factors that may be kind of pushing them away or kind of shying them away from surgery, because it may be something they heard, and you can probably go ahead and squash the misinformation like right then and there. They may just be having that in the back of their mind but afraid to say it.
Right. So now let's talk about the disparities in healthcare amongst this community. So we know that Black women have decreased rates of breast reconstruction. So what are things we can do as physicians to help change this? And does it help to have liaisons within the medical community, such as patient navigators? So in my system, which is Grady Hospital, there are patient volunteers who serve as mentors for other patients in the system. Unfortunately, that was shut down with COVID, so hopefully they'll bring it back. But do you think having a liaison such as this can help bridge that gap, so me as a Caucasian physician to African American patients to help educate?
Yeah, I think that would be great. I didn't even think about that, like a patient liaison to kind of help them navigate what's going on. Uh, you know, how to get to the laboratory, why are these labs needed, what is my primary care doing with this situation, just making sure everybody's all in one accord and they kind of know exactly what's going on with their care. I think another thing that could be done is when they get this diagnosis or that abnormal mammogram and they're meeting with a breast surgeon, I think that's really the crucial aspect right there, to like get them a referral, even if they're not interested in breast reconstruction. You still give them a referral. Well, this is a plastic surgeon, they can go over all these options. It doesn't have to be done like right away, or it can be done right away, probably. Just give them that referral so they can get more information, and then it's up to us. The ball's in our court to kind of like relay the information, show diagrams, give pamphlets, have maybe somebody like your nurse follow up with someone that may seem like on the fence or may not seem like they understand what's going on and be like, hey, we know you had your consultation. We were just following up to see if you had any questions, or, what are you thinking? How are you feel? Do you want to come back and talk again? Or, something like that, kind of like with like a close in the feedback loop or something like that, just to see how they're doing. I think that would be tremendous with those type of patients, just following back up and, definitely having the breast surgery team be like, no matter what, just go ahead and refer them to us so we can at least give them more information. And what they take from that is their own decision.
Yeah, I agree. I mean, I think that that's excellent what you guys are doing with medical liaisons. I mean, I wish that every patient could receive, that kind of like follow up and everything like that. Um, Going back to your question about the decreased rates of breast reconstruction, I think that we can do our parts as providers to really take the time to fully educate patients on their options before choosing one. And as I mentioned earlier, to try to really take the time to come to a decision as a team rather than solely relying on the patient to make a decision, and to really answer their questions on why they have any hesitancy to going with the treatment plan. And so, they may have some misinformation that you need to explain, maybe not that, maybe not true. Like, for example, that, breast implants are associated with, some vague illness, maybe not as factual as they think. And, we can cite data and show them journal articles and really even provide them with videos on educational material that can really teach them about the subject. And then then they're more informed and then can make better decisions about their care. And I think the follow-up is the key thing. I think a lot of people are lost to follow-up, and so we have to address the reasons why they're lost to follow-up.
Yeah, that's a very good point.
So we're going to kind of shift gears here. I think, some really important things have been brought up about patient care, some of the context behind why there's mistrust. I think as physicians and, myself as a future physician, it's really important to understand this historical context, approach patient care with that awareness. So you're not seeing a patient who's coming into the ED with this mistrust, delay of care because there's that mistrust. You're not looking at them as a train wreck. You're looking at this as an opportunity to educate, to provide good care, to rebuild trust that clearly is not there, that led to their delay in coming into the hospital system. And so, I think this is such an important thing for us to hear, for our audience to hear, and to really think about when you go into your practice, your day to day. For me as a medical student, one thing that I've tried to be very intentional about is starting at square one and understanding what my implicit biases are. I'm from the Midwest, a very small town. I did not grow up with a lot of diversity around me. And, I kind of assumed coming to a big diverse city that, all was well. But there are implicit biases that you have that you're not aware of until you sit down and understand that and say, this is a problem, and I'm going to be aware of that. And I'm going to approach patients and human interactions with that awareness. I think that's the first step to doing better. And definitely something I'm going to be intentional about as I start my training. So yeah, thank you all. If you want to comment on that, otherwise I'll kind of shift gears to the second half.
No, I think you hit the nail on the head. It's good to get that perspective because, people come from small towns and they just don't know, and they, you get hit with like reality, you get hit with real life, and it's just how you adapt. And if you're intentional about just trying to be a good physician, which means like being empathetic, being compassionate, like things will, definitely work on your behalf.
Yeah, I definitely think you're way ahead of the game, and I encourage you to, encourage your colleagues to do the same. And so I foresee good things with you.
Yeah, I appreciate that. I definitely have to credit. I'm here at UC San Diego. They do an amazing job of just kind of guiding us through the process. And we've got an amazingly diverse patient population, which creates those opportunities to be aware and to learn and grow. And, it's not too late. If you're already done with medical school, you're in residency, or you're a practicing physician, there's still opportunities to learn how to be better for your patients. And so I wouldn't see that as a lost opportunity, but rather just now is the time, and I'm motivated, I'm going to hit it, and I'm going to do right for the patients.
Well said. And I love how you said, be intentional.
Mm-hmm.
So that's what I'm going to think going forward.
It's been my word of the week. So to shift gears now, kind of towards the issue of lack of diversity in plastic surgery as a field, if we think about a 10-year plan, and the reason I say 10 years is we know that plastic surgery training takes a long time, whether you go integrated or independent paths. So what are some things we as physicians can do now to increase the number of Black and UIM medical students, applicants to plastic surgery residency, and in turn, plastic surgeons?
So I think like how most programs you have like a requirement of research. If you can sub out maybe one of those years of requirement of research, requirement of like community service for plastic surgery, like getting out there, getting into schools, hosting some type of program or something like that. Not just the regular mundane suture workshop, but suture workshop for like high school students, or give some presentation, show some gunshot wounds, stuff that's going to hit them and be like, whoa, because that's what they're going to want to see. I think that would, basically help, like kind of create a pipeline. And then from there, you never know, like with, when you're talking to undergraduates, that they'll pick it up, and talking to high school students and middle school schools, and even down to like elementary school students, just kind of like give them the bread and butter of like what it is to be a doctor, not necessarily plastic surgery. I think if you can get some like kind of credit to like, and I think residents would really put a lot of time into that, because they seeing, like, going back to seeing themselves like, oh man, I remember when I was at this stage. And you could like really have fun with it, because I've done a lot of these with different nonprofits in Tampa. And I mean, it's a lot of fun putting that stuff together. Like I went to a meat market, bought like these like beef hearts and like livers and kidneys and stuff like that. And you show these kids, man, they go crazy over it. I bought pig's feet. They didn't know how to suture, but it was just the act of like trying, like getting hands on. And I think if every other year, something like that, you can elect to do something like that. I call it community service to plastic surgery. I don't know a good term for it right now. I think that would really make some headway over time. Like you said, 10 years, it would really like start impacting, and maybe even get like the bigger societies, ASPS or the aesthetic societies, to maybe create a community service arm of like not necessarily like with drawing patients, but like trying to recruit, other minorities into the specialty.
That's a really good point that you bring up, because sometimes a lot of these projects, they'll have like a 1 year, 2 year, and then all of a sudden they'll die off. But the idea of, diversity is a conversation now, and hopefully it'll stay a conversation for 10 years. But just to have something that continues year after year after year, it's going to make a bigger difference than if it's just a year or two.
Yeah, I agree. I think that raising awareness and being mentors to underrepresented minorities in college or medical school is a great way to increase diversity in medicine, like Dr. Triggs mentioned. It's funny, funny thing, coincidentally today, the Arthur L. Garn Society, which was created in the legacy of Dr. Garns, the first Black chairman of plastic surgery, released a statistic today that according to 2006 data from the Association of American Medical Colleges, that African American and Latina physicians were severely underrepresented across all specialties, including family medicine, pediatrics, and OBGYN. And this disparity was perhaps most glaring for African Americans in plastic surgery. So we account for about 12.3% of the US population, but only represented 1.4% of plastic surgery faculty, which is crazy, right? And so, that can really affect Black physicians in training and plastic surgery training, because then that, they can have a lack of access to mentors. And to me, a good mentor can have a huge impact in the career trajectory of young, impressionable students. I know when I was in general surgery training, I volunteered with the local medical school to serve on panels discussing being an underrepresented minority in medicine. And I was able to be a mentor to a few students and still, even today, maintain those relationships. And so personally, I wish I had good mentors that looked like myself, because it can be hard to discuss the day-to-day challenges of being a minority to people that don't look like you. And so with that said, I think that another way that we can increase diversity is to update the admission criteria for med schools to evaluate the quote unquote distance traveled by each applicant. So maybe take into account factors such as the parental socioeconomic status, the hours worked while attending college, and even, the applicant's geographic location or the neighborhoods where they came from, because that can definitely affect the challenge of completing college. I think that people who've overcome hardships while growing up in school and are often minorities should be considered much stronger than someone who had a maybe easier route in life and got the same grades.
I'm a little curious, this is a side note question, but I'm a little curious what you guys think about, there's an argument that people, especially on the interview trail now for medical students, that these Zoom interviews have been horrible in terms of getting to know the person and like meeting them one-to-one. But the other argument is that for a lot of people, traveling and going to interviews, and especially going to a lot of interviews, that's a lot of money that some people might not necessarily afford. And what do you guys think about Zoom interviews basically creating a equal platform for everybody to have access?
I feel like the socioeconomics affects people before the interviews more than anything. Like once you get the interviews, people are going to take out the loans and stuff to travel if they have to. And so, I think that Zoom definitely helps, save some people some money, but I think we need to address it earlier, like even earlier, and make it, easier for people of color to get those types of interviews and figure out what we can do to get them there.
True. And since we're on the topic, on that same 10-year plan that Greta just brought up, how do you guys think we can increase the number of African American members in our American Society of Plastic Surgery organization or any professional society in plastic surgery and bring them up into leadership positions?
Oh, that's a tough one. I thought about that a couple of weeks ago, because when you go to these conferences, I mean, it's like few and far between. I think the Arthur Gaines Society is trying to kind of help with that, increasing the diversity. I think if you invite more minorities to speak on like either their practice or something they may be doing, or just even their experience as being a minority plastic surgeon, I think that would help, like getting more minority speakers, because then they tend to, either invite other minority plastic surgeons, or it just gets them more engaged. And I think they don't feel as shunned out, or maybe like, not really given the gratitude of, what they're doing right now. I think that's one way of doing it, but I really don't have any other like really solid plans outside of that.
Yeah, I think a big problem is that we just need to bring more minorities into the field, and then I think slowly that would trickle down and get more faculty in these positions of leadership. When you have that, 1% of plastic surgeons being African American and compared to 12% of society being African American, and that's a huge discrepancy, and we need to do better getting more, people of color into the field.
Yeah, I completely agree. And I think the data point you brought up before, where there's just underrepresentation across the board, all specialties, especially plastic surgery, I think the goal has to be get more people into medical school, absolutely, and consider it a win if that happens. Then consider it a win if they want to do surgery, and then consider it a huge win if they want to do plastic surgery. But all of those steps are equally important. We don't need to tell someone who's 12, 14 years old, you're going to be a plastic surgeon. We need you. No, we need you to be a physician. If you happen to want to do plastic surgery, that's a big win. If you want to do surgery, huge win. Very few minorities in those fields. And I think that's so important. And to make that goal a little bit broader than just ourselves is, just an important thing to keep in mind as we approach some of these initiatives. It's not a loss if that person doesn't end up becoming a plastic surgeon. If they get through the door into medical school, that is a huge win.
Totally agree.
Absolutely.
All right. So my next question for you guys. So what can we do as a society to help young surgeons in training face the challenge of being a minority in this field in plastic surgery?
So I think finding a mentor is key. I think, which can be hard in itself, because they can help you kind of navigate certain situations, make sure their applications are good, make sure they're doing what they need to be doing in terms of prepping for cases, or like even before then, how to study, what's important, what's not really important, to kind of, like I said, navigate the landscape. I know our program was really close. It was almost like a family type of atmosphere. And so sharing resources, like we have like a box where it's like, all the textbooks and things like that, guides like for each rotation that's updated like after every core group that rotates through that rotation. I think the chiefs in the upper levels talking with the lower levels on, almost like a consistent basis, team building exercises. I think all that helps build or fosters a community within the program that, will help not only just like minorities, but also just the program in general to work better and work more efficiently. I think just trying to foster a family type environment where it's easy to approach your chief or your upper level about a problem that's going on, because they're going to relay it to the attendings and they can have your back. And of course, the attendings, they're not going to like want you to go astray and things like that. And so that's something that can work on or work with you or, provide other resources for.
Great. What about you, Dr. Keys? Do you have any thoughts?
I think that the number one way we can help young surgeons and trainees is to really diversify the faculty at medical schools and academic teaching institutions.
Yeah, absolutely.
Historically, studies have shown that minority students consistently receive lower grades and worse evaluations during their clerkships compared to white students, even when controlling for variables such as exam scores, age, and gender. And so, as we all know, clerkships evaluations weigh heavily on how a dean's letter is written. And so that can really significantly impact one's career trajectory. And so if minority students are getting worse evaluations, then this can lead to a less than stellar dean's letter, which can really make the difference between someone matching into a competitive field like plastics or not. And so also by having more diversified faculty, it'll be easier for trainees to find a mentor like Dr. Triggs mentioned. These mentors will look like them and talk like them, and they probably have insight into the challenges that these, students and trainees are experiencing and can give them solid advice. And so I think diversification, again, is the key.
Yeah, absolutely. I just wanted to kind of wrap up with a little bit of advice giving session. One thing through our podcast platform, we've had a lot of great conversations with pre-med students, medical students from all walks of life. Frequently, questions come up about the competitiveness of the plastic surgery application or challenges that they might anticipate in training as an underrepresented minority. And so I just wanted to ask each of you, what message or advice would you have for Black and other UIM medical students who are interested in plastic surgery?
My advice is don't give up, think outside the box. That's what plastic surgery is all about. And so just really grind it out, find the mentors that you need to connect with, do your research early on while you're in medical school, seek out the opportunities to shadow physicians in the field that you're interested in, and just really go for it. Don't let anyone hold you back. Everyone's going to say, oh, you can't do this, can't do that, but you can do it. And even if you have to take the long way around and do some extra training to get there, by all means, if that's your dream to really get to where you want to go, then do it. It's totally worth it.
Yeah, I totally agree. Just to piggyback on that, I think if you are thinking about plastic surgery, I think, of course, a lot of times you get exposed to the cosmetic aspect, but shadow like academic plastic surgeons so you can kind of see the real deal of what we do, like from cosmetics, hand, burn, micro, because I think at that point you'll get a better appreciation and you'll really want to jump into the specialty at that point, because you can walk out feeling like you can really do anything. You can operate from the head to the foot, saying neonates to the elderly. So
yeah, buddy.
I think we're like under the radar specialty until you rotate onto a plastic surgery rotation, because we've stolen many a general surgeon interns when they rotated on for the burn service and saw exactly what we did.
Absolutely, for sure. I mean, especially breast reconstruction. I mean, there's so much that we do that is so important and is so needed by patients. And a lot of medical students do not realize what we do. All right, everyone. So thank you for your participation in this incredible discussion. So for our listeners, everyone, take the time. I want you to follow our guests on Instagram. They spend a ton of time, a lot of their valuable time serving as role models in our field. And I truly believe the value of social media, including this podcast, is to harness our platforms for education and for mentorship. And I will put their handles in our show notes. So all you have to do is click on it. It'll go straight to their Instagram page.
Since we're on the topic, in addition, you can follow us on Instagram at The Loop Podcast, where we give you daily updates.
If you like our content, make sure to subscribe, rate, and comment as we will continue to improve for our listeners.
Again, thank you, Dr. Triggs and Dr. Keys, and to our listeners. You are now in the loop.
Thank you so much. It was great talking to you guys.
Thank you.
Thanks.
Thank
It's
you.
dope. This was dope. I appreciate it.